Excuse me. Hey, everybody. Today we're covering common mental health diagnoses, and we're going to discuss traumatic brain injury diagnosis. I wanted to throw in dementia diagnoses because there's quite a few that fall under that. But for the sake of time, I think that will have to be a different one. But we'll touch on it just very briefly. But yeah, today we're going to cover mostly mental health diagnoses and TBI. So let's start with mental health diagnoses. So when we talk about mental health diagnoses, we can kind of think of them as falling into two different categories. There's more, there's a lot more. Um, but for the ones that we're going to cover, it's kind of easier to think of them as thought disorders and mood disorders. So when we think of thought disorders, um, it affects the way a person thinks. Um, Delusions and hallucinations are common. So delusions are false beliefs, believing that somebody's out to get them, believing that they're God, believing that I had somebody who used to believe that like Donald Trump was their best friend and that he had all this money from Donald Trump. So any kind of like those false beliefs, we've seen them before, is a delusion. Hallucinations are um, uh, like sensory things. So you can have visual is a big one, visual or auditory. We see that a lot with our residents, but you can have a hallucination with any sense. They can be smell, they can be touch, um, hearing. There's a sense I'm missing, taste. So a hallucination can be any sense, but I think hearing voices and seeing things are the two that we see most common. And so with patients that we work with, schizophrenia is kind of the thought disorder that we see the most common. We do have people with who have had just, brief psychosis episodes. Bipolar is kind of both that we'll see. But I think schizophrenia is the big one that we're going to see that falls under kind of a thought disorder. And then we have mood disorders, which is affecting the mood of a person. So the common diagnoses we see there are like depression, anxiety, mania, anything that affects the mood of an individual. As far as what causes a mental health diagnosis, we don't really know. We think that we know that there's a lot of factors in play. So a big one is genetics. You're more likely to have a mental health diagnosis if somebody in your immediate family had one. It's still not a super high correlation, so you're not guaranteed to have schizophrenia just because your mom had it, but you do have higher chances. Biological, we know that there is often a chemical imbalance in the brain with a lot of these mental disorders. So there's been MRIs, there's been scans, all kinds of stuff that show us that people with mental illness have impairments in their brain that are different from people without those mental illnesses. So there is a biological component that affects the brain in these individuals. Environmental, people's environment 100% affects the development of certain disorders. I shouldn't say 100% because it doesn't mean, it doesn't mean that if a certain thing happens to you that you are going to have a mental health diagnosis. But we do see that in certain environments, you're more likely to develop mental health diagnoses. So for some reason, people who are in cities have higher rates of mental health diagnosis than people who are in like rural areas. Um, People with like schizophrenia, uh, like upwards of 80% of people with schizophrenia have had some sort of abuse as a child, sexual abuse, physical abuse, neglect. So the big correlation between abuse and developing a mental health diagnosis later in life. And we see that with a lot of our patients. Unfortunately, a lot of them do have that abuse background. So environmental is a big part of it as well, and physical health. So certain physical conditions can produce certain kind of like psychosis or mental health disorders. Like Parkinson's is a big one where you can see some psychotic symptoms in there. And how we treat mental health diagnoses, um, it's different. We'll break it down in a little bit, but it's always a combination. I shouldn't say always, usually a combination. So medications, especially with thought disorders, medications are a real high priority. You can do counseling. People with schizophrenia do well, can do well with counseling. They can learn new skills. They can learn how to manage their symptoms in counseling. But if they're having really severe delusions and hallucinations, really the only thing that can help them are medications. Once they get those started, they might do better in therapy. Um, but that's why it's very important for us to make sure that we're working very closely with a psych provider because medications and thought disorders are very, very important and structured. So, um, people with mental health diagnoses often find themselves in, difficult situations. They, sometimes are unable to kind of thrive in society the way you and I are without support because they have these hallucinations or delusions, or their mood kind of affects how they can hold a job and do things like that. And so, structure is so important for them. So, we do a lot of things like scheduled meal times and scheduled snack times. And at first, they're probably not the happiest about it, but that routine is very helpful for them. Thought disorders and disorders can affect their sleep-wake cycle. So sometimes people are up all night and then sleeping during the day, and then they miss meals, and then they forget their meds. So structure and routine is very helpful in keeping just things very structured in their life, keeping their medications on track, keeping their symptoms in order, and things like that. So therapy can be helpful, individual therapy and also group therapy. So let's talk about schizophrenia. I would say that's the biggest thought disorder that we're going to see here at Blue Sky. Sorry, going back real quick. Another category that we're just not going to touch on today because I don't think we really have anybody that falls into that right now, but we do occasionally is a personality disorder, and that's a very interesting one too. So maybe we'll go into that another time. But we do see that come up every now and then. But right now, I don't think we have anybody with that as a primary diagnosis. So schizophrenia is a thought disorder, affects the way somebody thinks. You can have hallucinations like we talked about, auditory, visual, olfactory, smell, touch, taste, anything, or delusions, which we have seen too, a fixed or false belief. Unfortunately, some people kind of get these negative ones. Like we had an individual who we used to have over at Santa Ana who had really struggled with delusion. She thought we were poisoning her and people were out to get her and gangs were out to get her. And that's just, I mean, that's so hard to see and it's sad. But you can also see people with like really kind of manic delusions or kind of upbeat delusions where we have somebody at Santa Ana right now who has, voices that are her friends and she, thinks Michael Jackson's her boyfriend sometimes. So like she's kind of living it good. And when somebody has kind of happy delusions or hallucinations, if they're not really impacting their life, we don't really want to tweak it too much because that can, sometimes cause depression if they're talking to these friends and now we take them all away, especially if they've had them for a long time. But just be aware that that's a key component of schizophrenia is hallucinations and delusions. Another one is a flat affect, which we have seen. People don't always have it, but you do see it. It's pretty common. We have Carlene over at Colt who has a very flat effect. So like you see, like kind of hard to get a smile out of her. And we've had people in the past who kind of have that affect. It's a key component with schizophrenia. You can have a lack of motivation, social withdrawal, reduced speech, or like really disorganized speech, which we have another individual right now at Colt with that disorganized speech. Sometimes they call it word salad, like it just kind of makes no sense. But we just kind of take our time and try to understand what their needs are. Can have trouble with memory, focus, and executive function. So executive function is like the front of your brain, like planning, organizing. They can have difficulty with that. We hear schizoaffective a lot, which is schizophrenia plus a mood disorder. So it's just kind of like a combo diagnosis. So maybe you have schizophrenia and depression, or schizophrenia and anxiety. It's just schizophrenia and a mood disorder. Um, Working with people with schizophrenia or schizoaffective, some things that we want to look out for, medication compliance, it's super, super important. Like we talked about, thought disorders, they really need meds to be stabilized. Sometimes people can cut back at some point, but medication is very important. It's really hard to kind of do other interventions if your meds are not in balance. So, and we've seen this with individuals with some of those like negative delusions where they don't want to take their meds. That's common. There's a lot of side effects with these meds too. And so once people are feeling good, a lot of times people decide to stop their meds because they're feeling good. They don't think they need them anymore. And then they spiral, and then the delusions increase, and then it's really hard to get them back on meds. So medication compliance is important. That's why I always check for like cheeking meds or hiding meds. Or if we notice like, oh, they're starting to see some more delusions, we really want to get psych on board quickly before that spirals. It isn't uncommon for people to get like can't find the word I'm looking for, but kind of get um, adjusted to their meds so much that they don't work anymore and they kind of need to tweak in their meds. That does happen. So sometimes out of nowhere, they start to see more symptoms. You're like, I don't get it. They're taking on their meds. It happens. So we just need to kind of work really closely with the psych provider to make sure that we're relaying any symptoms and make sure that patients are taking their medications. Be on alert for increased psychosis symptoms and report those immediately because we have seen that spiral with people, and that's really, really hard when they get so psychotic that they don't trust us. They don't, it's really hard to do anything if their psychosis is out of control. And like we talked about, we want really supportive, really stable environments. It really helps when they trust people because a lot of times they're paranoid and they don't trust people. So developing a good relationship with them, having a stable environment can be very, very helpful. These are some mood disorders. So we were talking about thought disorders. These are mood. They're not completely separate. Mood can affect the way you think, but in terms of kind of categorizing them, it's easier to think of mood and thought. So these are mood disorders. So mania is a type of mood disorder. Um, and for all of these diagnoses, these are really brief versions. They actually all can be split into like even more detailed diagnosis based on how severe their depression is, how often they're having depression. So these are really brief overviews of them. Like even when you look at their diagnoses, you'll see like depression will be listed as like major depressive disorder, reoccurrent, moderate, in remission. So it's like it's very jargony, but this is kind of an overview of it. So mania um, is a period of increased energy, mood, or irritability. So you can think of like if you look over at this picture here, mania would be like up here, like really happy, really high. Maybe you're like racing thoughts. Maybe you're not sleeping as much. We see more risky behavior when people are in mania. They might be like gambling more or doing drugs. They're just feeling really good, really optimistic, usually. Sometimes they can be a little like edgy. Depression is the opposite. So the depression would be down here. I hope you can see my mouse, but depression would be down here. Um, and I think we see that more, or we have seen that more at Blue Sky. Um, some people kind of operate in depression all the time, and that's a tough place to be. But um, sadness, tearfulness, hopefulness, irritability. We see loss of interest in hobbies, fatigue, insomnia. They can be oversleeping, extreme weight loss or weight gain, difficulty talking, persistent negative self-talk, increased risk of suicide or self-harm. Um, and so when we're looking at depression, we want to make sure that we are um, not just giving into those symptoms because that is a hard one. People really want to isolate. People want to stay in the room. They want all their lights off. They want to be alone. And it's kind of hard to get them out of that. So really encouraging activities. If they don't want to come to a group, okay, maybe we'll do a one-on-one visit with you. Um, letting Cyrus and I know if you see any worsening symptoms so that we can, I mean, there are medications for depression. Also individual therapy can really helps with depression. So lots of things can be done. So just make sure you're kind of reporting that to Cyrus and I and the psych provider so that we can make sure that those symptoms are being managed. Same with mania, we just don't see it as often. And then we have bipolar, which is mania plus depression. So another combo one. And if you can see the picture down here, there's different types of bipolar. One is more up and down, bipolar two is less. So bipolar is extreme shifts between mania and depression. People kind of inappropriately use that word sometimes, like, oh, I'm bipolar. It's not like every 30 seconds you're switching. It's usually several days you'll switch between mania and depression. And people that you've worked with for a long time, we call it cycling. We know what their cycle is. We know we can kind of see when they're changing. Higher rates of suicide in bipolar. Symptoms can be a mix of mania and depression, or they can be combined. Anxiety. We have a lot of patients diagnosed with anxiety, common one. Persistent or ongoing worry, often about things that you and I maybe wouldn't find worrisome. They just kind of perseverate and fixate on it. I think we can all think of some of the residents who have this one. Um, it can present as excessive or repetitive questions, pacing, easily annoyed, agitated. Physical symptoms may include increased rapid heartbeat, trouble concentrating, sweating. They may have issues in social settings, so they may not do well interacting with others because of their anxiety, or they may have like a social anxiety as well that kind of makes it hard for them to interact with people. They can be withdrawn and have difficulty sleeping. Um, I put this picture in here because there's a lot that can help anxiety. Anxiety is one that kind of has a lot of components. A lot of mental health treatment can as well. Things that can really help. So medications can help with anxiety. There's like long-term meds that people can be on. There's also PRN medications that can help. Like, if I'm feeling anxious right now, I can take a med and maybe like 15 to 30 minutes, I'll feel a little improvement. But some people, medication isn't a big component in their anxiety, and they do well with kind of the other pieces where like schizophrenia can't really take the medication component out entirely. Usually that needs to stay in there. But with anxiety, there's a lot of things that we can do. Uh, Individual counseling can be very helpful, learning some skills to kind of treat your anxiety. Group therapy can be very helpful. Mindfulness, like deep breathing. Mariella does a great job with all that stuff. So, and a lot of people have probably never learned how to incorporate these. So these are some things that we can kind of help them with. Learning deep breathing exercises, learning mindfulness techniques. Lifestyle is a big one. Like we talked about, a lot of our patients came from really chaotic lifestyles. So maybe they were up all night, they weren't eating right, they weren't sleeping right, they weren't exercising. That can just make your anxiety worse. So teaching them, really helpful lifestyle tips. And we also just kind of incorporate that a lot. We have healthy meals. We don't allow you to like chain smoke all day. Like you have to, operate on a smoking schedule if you choose to smoke. Like you need to have your lights off at 10 p.m. So there's lots of ways that we can kind of help promote a healthy lifestyle. Um, Yeah, a lot of the other stuff we go over in like groups and individual counseling is understanding their anxiety, asking for help, finding coping skills. Activities is a big key also in anxiety. And the same with depression too. If they're kind of withdrawing into their room, um, it can be helpful. We need to be aware that anxiety can be exacerbated by being in group settings. So maybe they're better for a small group. But, finding activities in group, whether it's painting or coloring or doing diamond art, that can kind of help with our anxiety. Here's how we can support individuals with mental health diagnoses. Um, Remember that no two individuals with mental health diagnoses are the same. So just because you've had success with, excuse me, one patient with anxiety doing this individual with anxiety is going to be very different. The same, intervention might work or it might not. So understanding that like mental health diagnoses, just because they're the same diagnoses, the people have very different needs, and we need to figure out what works for each individual person. We need to learn about our residents to understand their mental needs and symptoms. So what triggers do they have? So a trigger is an action or a situation that can lead to increasing mental health symptoms. So for some people, that's being in a group setting. Oh, that's a trigger. I get upset. Um, Sometimes for people, it's the time of the year. Um, Sometimes there's a reason for it, like, oh, somebody passed at Christmas, that's when I get sad. For some people, it's just, I don't know, it happens. It seems to happen that July is the time when, their symptoms start to increase. So summer could be a trigger. So watching out for those triggers, helping, supporting them if we see, a trigger happen. Oh, this resident who really sets them off is out in the living room today. How can we kind of keep that from exacerbating the situation? And then coping skills. What coping skills do they have? Because a lot of our patients already have them. They just don't know they're called coping skills. Coping skills is a skill that can help them decrease their symptoms. So if they're anxious, they might not realize like, oh, actually, when I color in a group setting with two or three people, my anxiety is a lot better. Maybe they call a friend or they call their family member, and that really helps too. So helping them kind of identify those coping skills, and also giving them opportunities to use it. So maybe we do some more groups where they can learn about some new coping skills and implement those as well. Individuals. who have spent most of their adult life with diagnoses have developed ways of dealing with managing symptoms, which have helped them but may not be the healthiest. So mental health symptoms usually emerge like 20s and 30s. So most of our residents have dealt with this for a long, long time. And they've persevered. Like they found a way to keep going. Not, it might not always be the healthiest, but they have found ways that help them. And we kind of need to recognize that, oh, that worked for them, but it's not healthy. Let's see if we can find a better way for them. But, they're probably just doing what they had to do at the time to make life bearable or whatever. A lot of people resort to drugs or alcohol. We know that's not healthy, but if you have severe psychosis and or depression, it's a quick way to numb the pain. Not healthy, but a lot of people that's a common one that people use. Manipulation. So if you have, for example, um, um, a drug-seeking behavior, like you're really after opioids, you might learn to manipulate people because that's how you get what you need to get. And then that kind of rolls over into other areas of their life. They can be a very manipulative person because they learn that that works, that they get what they want that way. Lots of other behaviors, demanding, verbal aggression. They all likely have had some success in dealing with their symptoms in the past, but they're not healthy. So we need to help them learn about new ways. And we do that a lot of times, like just subconsciously through the routine of blue sky. We're not going to let you have drugs and alcohol here. We're going to lock up all the opioids. We're not going to let you chain smoke all day. Chain smoking is a really common uh, like intervention tool for people who have psychosis. It can be very helpful. It does help with a lot of symptoms of psychosis, but we know it's not great for your physical health. So, just our routine is going to help with a lot of these behaviors, and then helping them find new ways to deal with the symptoms, medications, coping skills, whatever it is. We support these individuals through a variety of ways, including treatment plans. So our treatment plans show if a resident is having a behavior, how can we help them with that behavior? In the past, they might have chose one of these unhealthy coping skills. If they were depressed, maybe they drank alcohol. That was helpful for them. But instead, we're going to put in their treatment plan if they're having symptoms of depression, we're going to offer them more one-on-one activities. We're going to encourage them to come to group. We're going to talk to the psych provider. Structure and routine, like we touched on, people with mental health diagnoses often kind of fall into really unhealthy routines. So we're gonna have scheduled smoke times, scheduled meal times, times that they need to have their lights off to encourage good sleep at night. We have consistent and amazing staff. Other places, bigger places, I've seen, staff turnover can be so hard on the patients. Every day you're adjusting to a new staff. You build a relationship with one staff, and tomorrow you got somebody brand new. So our consistent staff is such a help with dealing with mental health diagnoses. Not dealing with it, but supporting it, I should say. Activities, counseling, therapy groups. We talked about how all those are really helpful with mental health diagnoses. All right, cookie model. It's kind of an analogy that we use with dealing with dementia versus non-dementia. And like I said, we're not getting too much in dementia today. And it's not a clear-cut line down the middle. You will have people who kind of fall in the gray area, people who have dementia but fall into the other category. Or, we think that, oh, dementia is all 81st and Vista, and people at our behavior homes are non-dementia. Maybe they don't have a dementia diagnosis, but they maybe still fall into the dementia category because of other cognitive impairments. So it's not clean cut. I hope that doesn't make this too confusing, but this model can be really helpful in understanding how and why we do certain interventions with behaviors. So let's start with dementia, so the left side of the screen. The analogy is if you were at a grocery store with your young kid and they're in the shopping cart, you're trying to get all your groceries and you're just trying to get out of there, and your kid sees a cookie at checkout and they start screaming and crying because they want a cookie. They're causing a whole scene. What do you do? Do you give them the cookie to make the incident just go away? Or do you not give the cookie? Because they need to learn you can't act like that to get a cookie. So when we use the cookie model and what we're doing, we want to think dementia, you can give the cookie because they're not going to remember that their temper tantrum got them a cookie. However, on the opposite side of things, with non-dementia, if we give the cookie, they're going to learn very quickly, oh, when I act up, I get a cookie. Or it doesn't have to be a cookie, whatever it is, the cigarette, the extra plate at dinner, whatever the thing is, we don't want to give it because maybe that's going to stop the problem right now, but we're going to cause a bigger problem in the future. So when we think about dementia and giving the cookie, treatment plans and care are focused on distracting interventions. So we can give the cookie. If they're having a meltdown and really unstable, whatever it is, if it's an extra cigarette, if it's a cookie, normally, I'll say normally we can give it. We know that we have some residents that we cannot give it. So it is kind of a case by case basis where if they have good enough memory and cognition, this isn't going to work. They're going to learn that they can act up and get bonus or whatever. We want to provide environments and activities that comfort the resident and decrease stress, which could cause behavior. So really calming environments, music. We're just really, really focused on keeping the residents calm, and regulating their emotions because a lot of times they don't have the cognition to be able to do that themselves. They can't say, oh, I'm going to use my coping skill today. They don't really have the cognition for that. We want to attempt to teach residents how to act and behave through interventions. Sorry, attempting to teach residents how to act and behave through interventions is also ineffective due to worsening cognitive function. So if I try to teach Bradley how to not wander the house by giving him, a lecture on the dangers of wandering outside in the heat, it's not going to work. He doesn't have the cognitive capacity to do that. Um, it's ineffective. So we can try, making a room for Bradley that, we know Bradley will like. It has treats in there and it has calming music and noises or, a TV show he likes, whatever. We want to distract and keep him comfortable versus trying to teach him a new behavior. Um, some residents with dementia can still learn, but it's not going to be through that model. It's usually through I'm sorry, not through that kind of technique. It's going to be more through like modeling, like you seeing my behavior and you kind of copying that. That's going to be more effective and kind of structure and routine, having meal times at the same time, having smoke times at the same time, day after day after day. They might learn, that routine. But it's not going to be by me giving you a lecture or teaching you about an intervention. So on the opposite side, non-dementia, that's going to be most of our people at Chandler and Santa Ana. Our treatment plans are focused on helping them learn appropriate ways to manage their behaviors through interventions. So we're really trying to teach them new skills here, right? In the past, you use alcohol. Now I'm going to teach you how deep breathing and getting quiet space can be really helpful instead of alcohol. Environments are still comfortable. We don't want to make our homes like chaotic to where it's going to cause behaviors, but we want to allow them growth opportunities. Like they can, I still want you to go out and go to a movie where somebody with dementia, that might just, we know that's just going to set them off. But I want you to go out and go to a movie. And if it makes your behaviors worse, then maybe we'll kind of work with how to help you in that situation. Um, so there's going to be more kind of uncomfortable situations, but growth opportunities. Residents are gonna have the capability to learn through interventions. We giving into tantrums may lead to worsening behaviors long term. So if somebody's cussing and screaming and because they want the soda, if I give them that soda, they've learned that's how they act in the future to get that soda. Residents learn best through effective interventions, like treatment plans, but also modeling. Modeling is still very important in both models. Okay, real quick, let's touch on traumatic brain injuries. Traumatic brain injury is a disrupt in brain function, so an impairment in your brain somehow through a traumatic injury to your head. So somehow your brain function has been impacted through a traumatic injury. We see car accidents a lot, but if you've been around enough, you see some pretty unique traumatic brain injuries. I had a guy who fell off camelback. I've had like people who got football injuries in high school. So really, anything that hits your brain really hard or your head really hard can cause a traumatic brain injury. And there's different levels of it. Anoxic brain injuries are brain injuries caused by a lack of oxygen to the brain. So your brain functioning is still being impacted, but this time it's not from like a hit to the head, it's from you're not getting oxygen to your brain. So heat stroke is a common one in Arizona. We have a couple people who have drug overdoses. So they overdosed and didn't get oxygen to their brain for several minutes, causing an anoxic brain injury. Sometimes that happens like in birth too, in younger people, like an umbilical cord around the neck. So anything that could cause a lack of oxygen to the brain can cause an anoxic brain injury. Strokes are, we have a lot of people out there with strokes, which are brain injuries due to the lack of blood and oxygen to the brain. It affects the opposite side of the body. So you'll see people who, like, the right side of their body is impaired, but that's because the stroke happened on the left side of the brain. So your opposite side of your brain affects the opposite side of the body. And right versus left hemisphere strokes are very interesting, and different behaviors. So someday we can get into that and go over how right versus left hemisphere strokes are can cause different behaviors. Um, some things to know about TBIs. You don't need to know the Glasgow Coma scale, but that's a scale on how they rate TBIs. So when somebody comes into the ER, they are going to see like, oh, your conscious level. Like, are you not conscious? Are you somewhat conscious? If the injury, like if you had blood or if you have like a wound actual coming out of your head, you get different scores. So it's just to say that no two TBIs are the same. And we've seen that. We have multiple people with TBIs. They're very different. So, they can be very different kinds of TBIs and they have different symptoms. People can improve from a TBI. Some people improve dramatically where you wouldn't even know. But the first few months are really essential. So if we get somebody who comes in with a TBI and they're a fresh TBI, we might see a lot of improvement. People who've had, we're getting them. We had somebody recently who had a TBI when they were 17, and we got them, I think maybe 40 or 50. We're not going to see that big jump in improvement. This is kind of already their baseline, um, where they're probably going to stay. TBI symptoms can be very, very frustrating for the people who have the TBI. Difficulty of word finding. It really matters where in the brain that you got the TBI because that kind of has impacts what symptoms you have. But difficulty of word finding is a common one, and we've seen that with a lot of people up there. Quick tempers, especially if the front of your brain is impacted, your executive functioning, can have a very quick temper. Confused, difficulty managing your emotions. I think we've seen all those with our TBI individuals. I won't go over all this, but I thought was a really interesting graphic that shows the different parts of your brain, the different lobes of your brain, and what they um, kind of control and what can be affected. So if you have an injury to like your frontal, the front of your brain, or your occipital, which controls your vision, um, this is how it can kind of affect somebody with a TBI. So it's very interesting. So screenshot it if you want and look over it. And also like your brain can split in half. So you have all these lobes on each side of your brain. So somebody with a stroke, really all of these areas can be effective depending on either whatever side of a stroke that you have, right or left. Here's how we support individuals with TBIs, traumatic brain injuries. Remember that no two individuals with TBIs are the same. So like we talked about, everybody has a different area of the brain that was impacted, a different severity on the Glasgow scale. TBIs are very different. We need to learn about our residents to better understand their TBI and their symptoms. So when did they get a TBI? Like we talked about, that's important. Was it 3 months ago? Was it 30 years ago? That kind of gives us an idea of maybe if they're going to improve a little bit or if this is kind of their baseline. What are their symptoms and their limitations? Do they struggle with speech? Or do they struggle with vision? Are they quick to temper, quick to upset? And what do they need help with? Is it their left side that's impacted and they need help kind of shower, things their left side? A lot of times, like Mark up at Vista, he's really compensated. He had a stroke a while ago. I think he used to be right-handed, and I think his stroke affected the left side of his brain to the right side. So now he writes with his left hand. So people can, compensate from that, or they may need help in those areas. And then what are their strengths? That's really important too. Because so often we look at the things that they can't do, and that can be very frustrating for somebody with a TBI. Especially, somebody with Mark who had a very successful career. He was very active. He did a lot of things. We want to find out ways that we can encourage that to continue now. So finding his strengths, finding things that he can be proud of and have good self-esteem and enjoyment in doing. We want to provide a home environment, so we want to make things comfortable. We know people with TBI can be very quick to upset. Learning new things can be very difficult, so we want structure, we want routine, we want to keep things the same, and we really want to go slow. So direction should be short and simple, one step at a time, instead of giving them lots of steps that can be really hard to process. Allow them time to process. When you're talking to them, allow them to, but it can take up to a minute to kind of think and process an answer if they can. So go slow when you're talking to them. Don't kind of rush them. Don't put words in their mouth. Oh, this is what you were going to say. Go really slow and wait for their response. We support these individuals through a variety of ways, including our treatment plans that show us kind of what we know so far about the individual and how interventions can help. But as we get to know them, you might find a new intervention that works, and we'll put that in the treatment plan too. So let us know if you're finding a new intervention that's really helpful with them. Structure and routine, very important with people with traumatic brain injuries. Meal times, smoking times, everything the same. They don't have to learn every day what time meal is. That could be a really big upset too. If yesterday meal was at 10 and now it's at 11, that can be, just a trigger to really upset them. So keeping things the same is very helpful. Consistent and amazing staff, like we talked about. We don't want to over confuse them anymore. So same staff, comfortable staff, building a good relationship. Activities, counseling, therapy groups can all be helpful. And physical occupational therapy can be helpful, especially if they're early on in their traumatic brain injury journey. That can really kind of help them recoup um, if they can gain anything back. Physical and occupational therapy can be very important at the beginning to help them get that back. All right, so we have some discussion questions. We can go through these, or we can talk about individual patients or situations going on, questions you have on mental health diagnoses.